Thank you, Beth. Thank you, Tom, for inviting me here. Thank you, Dr. Sharma and Dr. Kinney, for allowing me to speak today. Okay, my name is Asif Shaikh. I'm the lead cardiovascular specialist here at Mount Sinai Fuster Hospital. And my topic of discussion today is mainly the mechanical circulatory support devices in the context of the cardiac cath lab. I have no financial disclosures to report. A little bit about our agenda, what to expect in the next few minutes while we talk about these things. What is mechanical circulatory support? I want to give you an overview of what some of the devices that we use here in our cath lab, and I want to go over the future of mechanical support. What is mechanical support? Well, the goal of mechanical support is to restore cardiac output to preserve end organ perfusion. Basically, we want to take over the function of the heart. Most of the devices that we will go over today will be talking about how we can augment our cardiac output and hemodynamics. In addition to talking about the cardiac output, we have to talk about offloading the left ventricle. Often in STEMI patients, even though we revascularize them after post-PCI, they still exhibit symptoms of cardiogenic shock. And you might ask, what's happening here? Well, the left ventricular myocardium is experiencing reperfusion injury, and they're also volume overloaded. So then the ventricle gets stretched, and which is actually increasing the oxygen demand for the patient. So if you can actually offload the left ventricle, shrink down, and decrease the LV-EDP, you're going to be promoting healing of the heart and decreasing oxygen demand. You want to optimize the balance between myocardial oxygen supply and demand, which allows time for the myocardium to recover. And some of the choices that we have available in our cath lab are, and this by no means is an exhaustive list, it's just a couple of things that we use, and I just wanted to give you a brief overview of what we use here in our cath lab. The intra-aortic balloon pump, Impella, and the extracorporeal membrane oxygenation, which Greg did a wonderful job in telling us about. And we're gonna go into that. So I broke down all the devices into two groups mainly. Some of them are continuous flow pumps, and some of them are non-continuous, like the balloon pump. And you could also break them down into intracorporeal or extracorporeal. Now, what modality we'll end up using basically depends on where you are, what the local expertise is, and the attending that you're working with. So what do these devices look like, and what are the pluses and minuses of each? Okay, first let's talk about the balloon pump. So the idea of the balloon pump is rather simple, relatively speaking. We use a helium-filled balloon, so it's a pneumatic or pulsatile device. It's inserted retrograde through the femoral artery, and it goes up into a 7.5 French sheath in arterial access, and we basically place it in the distal aorta. So it's essentially a catheter with a balloon wrapped around it. As you can see in our little diagram, it's inflating and deflating in synchrony with the cardiac cycle. So it inflates in diastole and it deflates in systole. And what does that mean? So why do we care about this? So as you know, the heart relaxes in diastole, and it allows perfusion of the coronary arteries. So in diastole, the balloon inflates and the aorta blocks blood moving forward. So what happens, it allows more blood to backflow and perfuse the coronary arteries. And this is a great choice in our cath lab because patients that come in with, for example, an NSTEMI, and they have a severe three-vessel disease or left main disease, and you're waiting for them to undergo a complex PCI or CABG, you'd want we call it a bridge to therapy. You want to use something like this or consider using something like this so that you can help the patient augment their coronary blood flow. Now, in systole, you increase the coronary blood flow. So in systole, that's when our balloon deflates, right? So when it deflates, it creates a vacuum effect. You end up pulling more blood out of the ventricles, effectively reducing the afterload. And so that's the power of the balloon pump. It has two great functions. It actually helps you perfuse the vessels in the heart, and it decreases the afterload, which helps the heart get back to its primary, how it was. So what are some contraindications of a device like this? One, an absolute contraindication that you would consider not using the balloon pump is somebody who has a aortic valve insufficiency. In the picture, as you can see, like imagine you have aortic insufficiency. Now you're blocking up the blood from exiting the ventricles, and in diastole, the blood's leaking back. So you're going to end up putting more blood back in the left ventricle and worsening the regurgitation, and you definitely don't want that. Another contraindication of using balloon pump is anyone who has aortic dissection. Imagine you have a patient with a small aortic dissection, and then you end up putting a balloon pump in the aorta and inflating it in diastole. You can propagate the aortic dissection all the way down, and this is it can become very, very bad situation. And then we'd call Greg to put in the ECMO. All right, so let's talk a little bit about the Impella CP. So here I'm going to be talking about specifically the left-sided Impella, which we have two options, the Impella CP and the Impella 5.5. I need a breath, yeah, sorry. This is a microaxial flow device. It's basically a suction catheter. I like to think of it as a suction catheter, that's what it is. Basically, it pumps the blood for the heart. It allows the muscle to rest and recover. The device goes retrograde through the femoral artery, and now the balloon pump, remember, it was a 7.5 French arterial axis. This is double that, a 14 French arterial axis in Impella CP, and for Impella 5.5, we'd want a surgical cut down because it's a little bit bigger. They're essentially the same, but they're a little different, but essentially the principle is the same of use. This is a pigtail catheter, and it has two ports. One distal port that goes all the way across the LV into the LV across the aortic valve, and this basically sucks out blood from the LV and ejects it into the proximal port, which sits in the aorta. Because the Impella fully unloads the left ventricle, it actually helps patients by decreasing the LV EDP and decreasing the mechanical work of the heart. It's a great option if the primary problem is low cardiac output or low EF, and the lungs are okay. Besides patients that have cardiogenic shock, we try to use it in our cath lab for patients with high-risk PCI prophylactically because it provides myocardial protection and it provides hemodynamic support. Okay, in high-risk patients. So a side note, I want to talk about the Impella being positional. Sorry. So it's very positional. So what that means is because we have to place the Impella across the aortic valve, there's two ports here, right? You want to place it properly, because imagine you place it too deeply and you have both ports in the left ventricle. So it's not going to help you much if you're going to take out the blood and put it back into the LV. It's not doing much. And if you place it too much into the aorta and not enough into the LV, you're going to be taking blood from the aorta, dumping it in the aorta, which is not really conducive to what you want to do. So what we do is we try to place it under fluoroscopy, and then after it's set in the right place, we try to keep it there. And so that's what we do. So it's very positional. Some things to consider while using Impella. If it's placed too deep into the LV, it can cause LV perforation. So you really want to make sure that it's in the right position. Also, some reasons why we wouldn't use it, some contraindications of use. If somebody comes in and they have really bad peripheral artery disease, you don't want to use it in this kind of patient, because to place a big 14 French sheath into the artery, it's not good. You need healthy artery, and for somebody like this, you would not want to use that. Also, since it's sitting across the aortic valve, you want to make sure the person does not have severe aortic stenosis or mechanical aortic valve. Also, anyone with the LV thrombus, you don't want to use this device. Imagine putting a Impella device into the LV and then you sucking out the LV thrombus and then shooting it out systemically and causing all sorts of other problems. You don't want that. You definitely don't want that. So now that we spoke about Impella, the left side Impella, imagine you have a patient that comes in with has a massive MI, and then now they have right ventricular failure and left ventricular failure. So that's why they came out with this Impella RP Flex. So if you put a left side Impella in this patient, what is it going to do for the patient? It's not going to help them with their right ventricle or right ventricular failure. So you want to use this one. That's where this comes in. It's same, essentially, microaxial flow pump. It's a 23 French venous axis. You can put it in the femoral or the IJ. Basically, it sits. It has the two ports, the input and the output port. It sucks blood from the vena cava and straight into the pulmonary artery, bypassing the right ventricle, and it's very beneficial for the patients who come in with the RV failure or infarct, because it allows the RV to relax and recover. Some considerations: you'd want to avoid this in patients with anybody with a pulmonary embolism or peripheral vascular disease. All right, now let's briefly talk about ECMO. Greg already went through it, and I just want to give you little points. What is ECMO? It's basically something that helps you in certain situations like a cardiac or pulmonary support. Anybody with cardiac failure or pulmonary failure, you'd want to use that. What does it do? It basically takes over the function of the heart. It pumps for you and it oxygenates the blood for you. Like Greg said, it comes out, you have a VA and a VV. The venous, it'll take, the VA, the venous arterial, will take blood from the venous side, put it through a centrifugal pump, oxygenator, and deliver it back into the artery. And this is great for patients with cardiac and pulmonary problems. So the VV, now you have the venous system, which is basically for a patient. We don't use it too much in the cardiac cath lab. It is for somebody with lung problems only. Some nice pictures that I wanted to add, and it's centrifugal flow. It uses a great bigger sheet, the 23 French. Like I said, you take out blood from the vein, pump, oxygenator, and bring it back to the arteries. It provides full cardiac support. So anybody with severe cardiogenic shock, respiratory shock, refractory cardiogenic shock, you'd want to use something like this in them. I like to consider it as a bedside heart and lung bypass. All right. So then you have a VV, like I mentioned quickly. It's a bedside lung bypass. You could think of it like that. Takes blood from the venous, put it back in the vein, and we recently did use it during COVID time for severe ARDS, which is acute respiratory distress syndrome. Bad lungs, heart is okay. Think about VV ECMO. Okay, now a little bit about the future of mechanical support. So finally, let's discuss about that. Every year, almost 350,000 people or adults suffer an out of the hospital cardiac arrest. Many strategies have been taken to improve outcomes. They've come out. We've all know that they focus on early bystander CPR, wider access to defibrillators, and high-quality chest compressions. These are all great, but imagine you have a patient outside and they're suffering from a cardiac arrest. After 20 minutes of resuscitation, if they don't get proper treatment or proper care, there's the chance of good outcomes are essentially zero. So as a result, many of the hospitals have thought about this, and Greg did mention about eCPR, this ECMO CPR. So what is the goal for ECMO CPR? It's essentially the same as MCS, or mechanical circulatory support. It's to maintain end organ perfusion, to make sure that the neurology, the brain is okay and everything else is working fine, and you save the patient. Some reversible causes, we want to take care of the reversible causes. Like if somebody has a major vessel blockage, we want to make sure that we can sort that out. Some pilot programs have been started in the US and Europe. For example, this picture, you can see that they're doing ECMO in Paris in the metro, in the train station. And then the other one is from Albuquerque, New Mexico. And they're performing ECMO outside in the field. Okay, and as you can imagine, making something like this work requires a lot of coordination between pre-hospital and hospital resources. Everything is still evolving, and some points, current eCPR protocols require that ECMO be started 20 minutes after resuscitation. And studies have shown that there are varying degrees of increased survival rate between 8% to 29%. However, the one thing that you can say is that it is a viable way of treating the patient. Okay, for the last slide, I wanted to give you a little oversimplified algorithm and a key takeaway, I call it my EF slide. So if somebody comes in with the EF greater than 35 and you want to do a simple PCI, then usually you don't need support, but you usually don't need support. If you want to do a complex PCI, then consider a balloon pump. Now, if the ejection fraction is 20 to 35% and you want to do a simple PCI, you can consider a balloon pump. And if you want to do a complex PCI, you could consider Impella. Now, if the ejection fraction is less than 20%, and you want to do either a simple or a complex PCI, consider Impella or ECMO. Thank you for listening. If you have any questions, please email.